The topic of today, we are going to cover heparin-induced thrombocytopenia. Kindly make sure you subscribe. It will cost you absolutely nothing. Let's dig in. So let's quickly look at the heparins. And under the heparins, we have low molecular weight heparins. And the examples include the parins. So anything that has parin is a low molecular weight heparin. That is enoxaparin, dalteparin, nadroparin, bemiparin, satroparin. And then the next thing is that the risk factors of heparins are less in low molecular weight heparin in comparison to unfractionated heparin. So it has a lesser risk of heparin-induced thrombocytopenia and osteoporosis. In addition to that, the reversal drug that we use or the antidote that we use in terms of low molecular weight heparin and unfractionated heparin, because just let me tell you, unfractionated heparin is a larger molecule, and then now from it we get low molecular weight heparin. So they share similar characteristics, but sometimes they do differ. So in terms of the reversal, on board we usually use protamine sulfate, but in terms of low molecular weight heparin, it has limited antagonism. And then we usually monitor low molecular weight heparin using anti-XA, whereas in unfractionated we usually use APTT. And then it is usually excreted through the kidney. So a patient who comes in, you want to give them anticoagulant, but their creatine clearance is less than 30 ml per minute. Then you'll prefer using unfractionated heparin because it is excreted by the liver. So unfractionated heparin, it has an increased risk of HTI in addition to osteoporosis, and then it has an increased reversal by protamine sulfate, and then it is monitored using APTT and is excreted in the liver. So in synthetic heparinoids, this somehow the way synthetic and low molecular weight heparins, they are similar in terms of their mode of action, and the mode of action of low molecular weight heparin and synthetic heparin is they stimulate antithrombin 3, which later inhibits factor 10A. Whereas in unfractionated heparin, it still stimulates antithrombin 3, but now after stimulation of antithrombin 3, it inhibits both factor 2 and factor 10A. So an example of synthetic heparinoids include fontoparinax, selective antithrombin 3 inhibiting factor 10A, and it is excreted by the kidney. So a patient who comes in and has a kidney problem, which drug do you give? Unfractionated heparin. Heparin-induced thrombocytopenia. This is when you have immune-mediated prothrombic disorder characterized by a sudden drop of platelet. So three things are happening in this statement. Number one, it's immune-mediated, meaning our body is attacking something in our body. Number two, it's prothrombotic, meaning we are forming clots. Number four, it is characterized by sudden drop in platelet, meaning it's either in this prothrombic situation we are consuming our platelets. So let's continue. This is a disease, as we said, prothrombic. This is a disease mediated by platelet activated antibodies. As we said, it is an immune disorder. Let's look at briefly at the pathophysiology. So the pathophysiology, when heparin is administered, because the disease is heparin-induced thrombocytopenia, when heparin is administered, then it binds to platelet factor 4. After binding to platelet factor 4, then it forms a complex. Our own antibodies, that is IgG antibodies, then can bind to this heparin and platelet 4, then forming a complex. Then after binding this complex, that is IgG, our IgG antibodies, our heparin and platelet factor 4, then activates more platelets. And then this makes little clots in blood vessel, resulting now to low effect in platelet in our bodies. So I hope you have understood the pathophysiology. So we said it is characterized by sudden drop of platelets. Let's look at how we can define this heparin-induced thrombocytopenia. So the first thing it is the platelet drops usually drop 50% or more from the baseline. That's why it's important when a patient comes in your clinic or your hospital, you take the baseline test, and those baseline tests should also include full blood count, where you'll get the platelet count. So your platelet count drops 50% or more from the baseline. Number two, or this platelet count drops below 100 times 10 power 9 per liters. So when it drops below 100, that is also significant of heparin-induced thrombocytopenia. Obvious after you have given heparin. In addition to that, when you have skin necrosis and when you have new new venous or arterial thrombosis when it occurs after initiation of heparin. So heparin-induced thrombocytopenia. Heparin-induced thrombocytopenia, it means that we have to take heparin for us to have thrombocytopenia. And just to give an introduction, we have two types of heparin-induced thrombocytopenia, non-immune and immune. So the one we are talking about today is the immune one. As you have said previously, that this is an immune-mediated, and this immune one is usually life-threatening. So it's the second common most effect of heparins after bleeding, and then it occurs in 3 to 5 of the patients after taking 5 to 10 days after initiation of standard heparin therapy. And then it can be left threatening, as I've mentioned before. And then it has lower incidence in molecular weight heparin, lower molecular weight heparin. So we have three types of heparin. We have low molecular weight heparin, we have unfractionated heparin, and we have synthetic heparins. So among the three, unfractionated heparin has a higher chance of a patient coming in with heparin-induced thrombocytopenia, whereas the low molecular weight heparin has a lower chance. Well, if you are to give a drug between the three of them, and you may not have heparin-induced thrombocytopenia, then you go for fontoparinax, which is a synthetic heparin. So clinical features, you'll have skin necrosis at the injection site, you have development of thrombocytopenia, you also have venous and arterial thrombosis. So we have a 4T scoring system. Just from the name, it's 4, meaning 4 components. T's meaning they have to start with T. And it's a scoring system that will help us in terms of diagnosing heparin-induced thrombocytopenia. So the first T is thrombocytopenia, which is just common as what you have been saying. The second is timing of platelet count. So when did this platelet count fall? In addition to that, thrombosis or other sequelae and presence of other causes of thrombocytopenia. So in each of these 4 T's, you give 2 points. So it can either be 9, then a level of thrombocytopenia 30 or greater than 50. So you're going to see in the next slide. So you give each of them from 0 to 2, 0 to 2, 0 to 2, 0 to 2, then you add the values. So if it's 0 to 3, then it means it has low suspectability or probability of us having heparin-induced thrombocytopenia. And with that rules out heparin-induced thrombocytopenia. But when you have intermediate, that is 4 to 5, so you have ruled each and for the four components, and you have gotten 4 to 5, then that means intermediate. When you've gotten higher, that is 6 to 8, because the maximum you can go is 8, considering we are giving each component maximum of 2 points. So for intermediate and high, then it means that the clinical suspectability of us having heparin-induced thrombocytopenia is high, and what you do further testing with immuno. So this is the 4T scoring system I was talking about, where we have the 4 components, that is thrombosis is the first T, thrombocytopenia is the first T, thrombosis or any other sequelae, timing of the platelet count, the T, other causes of thrombocytopenia. This T is what we are considering. So in terms of thrombocytopenia, if the platelet count is less than 30, then we give that 0 point. If the platelet count falls between 30 and 50, we give it 1 point, and if it falls greater than 50 or more, we give 2 points. Thrombosis or any other sequelae, when you have none, we give it 0 point. When you have progressive or recurrent thrombosis and non-necrotizing skin lesions or suspected thrombosis, we give it 1. When you have new thrombosis, skin necrosis, or acute systemic reaction after an IV, we give it 2. Timing of the platelets, if the platelet count falls less than 4 days without recent heparin exposure, that means our reason for the thrombocytopenia is not heparin. Then if our platelet timing that is consistent with 5 to 10 days, 5 to 10 fall, but not clear or the onset after day 10, or fall greater than 1 day without prior heparin exposure, 30 to 50 days. So this is a gray line where it may be consistent with 5 to 10 days of a fall, but it is not clear, or the onset is after 10 days, or the fall is greater than 1 day with prior exposure of heparin 30 to 100 days ago. So that will give 1 point, but when you have clear onset between day 5 to day 10 or greater than day 1, with heparin exposure within 30 days, then that you give it 2 points. Any other causes of thrombocytopenia, because you need to do differential diagnosis. If it is definitely it is caused by any other cause, you give it 0 point. If it is if you have possibly other causes, then you give it 1. No other causes of thrombocytopenia, you give it 2, meaning we highly suspect heparin-induced thrombocytopenia. So in terms of management, you begin with prevention. So this is after you have given your heparin, you carefully monitor your platelet count during that therapy. So usually after 3 days after the initiation of the heparin, and you repeat it after 6 days. So now the treatment is the first thing. You stop heparin platelet count when our platelet count reaches less than 75,000. When now you replace when you stop heparin, because you have to continue with blood thinners, you replace it with direct inhibitors of thrombin that include the deciridine or agobatran or dabagatran. In addition to that, you also avoid platelet transfusion, and the reason behind this is just you're feeding to the complex. What did we say our pathophysiology is? Our pathophysiology is when you have the heparin, it binds to platelet factor 4, and that complex affects IgG, our antibodies. And when it comes to bind, then it tells other platelets, come in, and do that we consume platelets. So if you give the platelet transfusion, it's like you're telling our body, take food, eat it. So you avoid platelet transfusion because of increased risk of thrombosis.